I'm Teresa Davidson. I'm the Executive Director for the Mid-South Liver Alliance. We have been in existence for about 3 years now. We started our 3rd year this year, and we really wanted to get the word out about chronic liver disease for kids. So we really do appreciate you coming out and, listening to Dr. Mohammed and maybe giving him some questions so that he knows things that you are interested in and want to do, and just kind of make sure that we're all communicating, because I know communication is the #1 thing that we need to do. And it's nice to do it out in public again at a restaurant. So I'm excited that this is our first one, so we're excited about that. The Mid-South Liver Alliance, this is what we do. We're committed to improving, educating, advocating, and supporting children, adults, families with chronic liver disease. In the Mid-South states of Tennessee, Alabama, Mississippi, Arkansas, Louisiana, and Kentucky. I'm a one-person shop and I have all those states. It's a lot of fun. But it's growing and things are starting to pick up, and I really think that we're going to see more interest in liver disease. There's a lot more things happening at the federal level. I've been very involved with advocacy with the Global Liver Institute, which is based in Washington, and I think you're going to see a lot of good things happening in the future, hopefully, with that. What we do is chronic liver disease, and all of these diseases help to make up a lot of the chronic liver disease that we see. We're trying to support patients. As we will build funds and have patient support funds, but at this point we don't have that yet, but that's to come. That is something that we do hope to come in the future. So I just wanted you to know that. So if you have patients that are having transplants and you have issues, do check with me. I might know some things that can happen, but we don't have the funds yet, but we're working on trying to get those funds together. This is who we are made up of, the Medical Advisory Board. I went to all the transplant centers in my 6 states, and these are the people that have come forward and been a part of my Medical Advisory Board and helped us over the past 2.5 years kind of start and try to figure out what we want to do and how we want to do it and the best way to get out there and get the education and awareness out there. And then our committee members, of course, Dr. Mohammed, Kaylin Adams, Jill Harlan, and myself. The board members, Chris Oubre, Jeff McElvain, Raketa Clark, they aren't here tonight. Most of them travel, and actually 2 of them are based out of Memphis. Only one's based here in Nashville. And we're trying to build the board across our other states too. So this year we hope to build more people. Disclosure of financial relationships, just that Dr. Mohammed is a presenter and planning committee for this educational event, and he's also a speaker for Myram and Embilio. So I just wanted to let you all know that. The other thing is the CMEs. I have a sheet for you to take with you that tells you how to get your CMEs at the end of the program. So just come back to the back table. It'll be out on the back table. And if you don't mind, turn in your name badges. I'll have a basket that you can put your name badges in, okay? And now we're going to have Dr. Saeed Mohammed come up and talk. I'm pleased to introduce him. He is recently joined VUMC as director of the Pediatric Solid Organ Transplant Center at Monroe Carroll Jr. Children's Hospital at Vanderbilt. So much to say. Dr. Mohammed is an internationally recognized pediatric transplant hepatologist. His clinical interests include liver transplantation, biliary atresia, Alagille syndrome, acute liver failure, autoimmune liver disease, and portal hypertension, all of those of which he's going to talk a lot about tonight. His research interests are focused on improving the long-term health outcomes of children with liver disease through providing new therapies, improving medication adherence, and measuring quality of life. Dr. Mohammed received his medical degree from Aga Khan University in Karachi, Pakistan. He completed his pediatrics residency training at Vanderbilt before moving to Northwestern University, where he completed a pediatric gastroenterology fellowship and a transplant hepatology fellowship before being recruited to Northwestern faculty. So now he's at Vanderbilt, and we're very proud to have him, and we look forward to hearing his talk.
So I wanted to thank Teresa first for kind of getting this started. Before coming here, I had been part of the American Liver Foundation in Illinois. They had branches everywhere too. And so I had done some speaking for them in the past, and I know what they sort of accomplished there, and look forward to working with you with this organization and spreading more awareness about liver disease. Before we start, I just wanted to know kind of where people are coming from. How many folks here are from sort of pediatric groups? All of you? And pediatricians, RNs? Okay. All right. And you guys?
LPNs and nurse practitioners.
Nurse practitioner. And you work for like outpatient practices in this area? Mm-hmm. Okay, perfect. Like Teresa said, I've been here now for about a year. So I've met some of the folks here. I think we're still looking for a pediatrician for my kids. But so maybe we'll talk after. So I'm going to talk about pediatric liver disease, some common manifestations, treatments, and outcomes. I don't have any disclosures related to this talk. We're going to talk about several liver diseases, so biliary atresia, Alagille syndrome, alpha-1, autoimmune hepatitis, and then probably spend the most time on non-alcoholic fatty liver disease. I think the first four are pretty rare, but the fatty liver disease is becoming more and more common. So in biliary atresia, it's a rare progressive disease of the intrahepatic and extrahepatic bile ducts and results in fibrosis and scarring of the liver. It usually presents in the first 3 months of life. So, the first, I'd say, at the 4-week check, we're really looking for you guys to be able to see if kids look jaundiced and if their poops are a normal color. I think jaundice can sometimes be difficult to pick up, but if you ask them what color the poops are, if they're not if they have some color in it, and as long as they're not the color kind of the wall, that's a good sign. It's pretty rare. It occurs in 1 in almost 20,000 live births. So it's estimated that a pediatrician in regular practice might see 1 in their whole career, once they're in the outpatient setting. But it's the leading cause of liver transplantation in pediatrics. So the etiology and the pathogenesis is unknown, but there are a couple of proposed etiologies. So there's thought to be a perinatal viral infection, abnormal bile duct development, a prenatal toxin exposure, or just a dysregulated immune response. What I always tell families is, it's nothing that the mom did during the pregnancy. We don't know exactly what causes it, and a genetic predisposition. So most kids with biliary atresia are healthy at birth, and symptoms will develop between 2 and 6 weeks of age. And you have jaundice, you have acolic stools. Sometimes you'll have poor weight gain, failure to thrive. Ascites, which is just fluid in the belly, is more common later, so maybe when they're 7 or 8 months old, and then hepatosplenomegaly, so you might be able to feel a bigger spleen when you do an exam. So we always get a liver biopsy to diagnose this, and it has a 90 to 95% accuracy. So the liver biopsy looks pretty normal, but you might see, so this thing here is bile in a bile duct, so we call that a plug. So that's a sign that there is biliary atresia. So we get we're sort of in a rush when we get these patients because we want to diagnose it as soon as possible. So early diagnosis is critical, and the surgery that's done to correct it is called a Kasai-Porter enterostomy, and it's a surgical procedure to restore bile flow, and the best outcome is if it's performed before 3 months of age. So there's a 75 to 90% 10-year transplant-free survival if the jaundice clears by 3 months of age. So it's a difficult sort of waiting period that the families have to go through. So let's say you do this surgery at 2 months of age. We really need to know, we really figure out what's going on by the time they're 5 months old, whether or not they've cleared their bilirubin. And we want the bilirubin to be less than 2. And there's only a 20% transplant-free survival if the jaundice persists past 3 months post-Kasai. And you move towards liver transplantation if the jaundice persists. So that's for biliary atresia. Next, I'll talk about Alagille syndrome. It's an autosomal dominant multi-system disorder. not defined by Notch signaling dysfunction. So Notch is a genetic mutation that's present in the majority of these patients. Liver disease does not usually develop outside of early childhood. So there are people out there who have Alagille syndrome who might be in their 30s or 40s. They may have other manifestations, but if they've gotten sort of that far, they're unlikely to have severe liver disease. Most of the patients that we see on the liver side, they're jaundiced at birth. They have, when we sort of test for things, we're looking at their bile ducts on a liver biopsy, and we see they have fewer bile ducts. This is also pretty rare. It's 1 to 30,000 or 50,000 live births. It's important to know it's a multi-system disorder. So, we see them in the liver clinics with this. You may see patients who have heart disease. So heart disease is very common. Kidney disease is common as well. These are some of the clinical manifestations. So a lot of these babies have poor growth. So we kind of say they're scrawny. They might be growing okay, but they don't have as much adipose tissue. They can have xanthomas, especially when they get older. A lot of them will have pruritus, which is itching. They can have developmental delays. They have some vascular anomalies, so they can have aneurysms. One of the things we screen for are brain aneurysms. They often have cardiac disease, and they have a typical facial phenotype, so they have kind of a triangular face with deep set eyes. I myself, I can't really see that very well, but sometimes if you have a family who have it, you can see the sort of the resemblance in the parent and the child. So to diagnose this, there's a molecular diagnosis, so genetic testing. But before that was really available, you would have a liver biopsy. So we'd see fewer bile ducts on the liver biopsy, and then you had to have 3 of the 5 of these features. So you had to have cholestasis or eye abnormalities, and the other one that's pretty common would be cardiac defects. We do x-rays to look for skeletal abnormalities. Sometimes you see them, sometimes you don't. But if you can't do genetic testing, which I think today it's pretty easy to get, you can diagnose them just based on this. Now there's a certain percentage, probably less than 10%, who have either new mutations or something we haven't discovered, so they may be labeled as Alagille if they have these manifestations. There's no treatment really for Alagille syndrome, and some patients don't need to be treated. They may just have congenital heart disease that gets operated on, and then they live fine after that. For pruritus, there's the medication called Livmarli, is a FDA-approved therapy for itching. You have to do vitamin supplementation for fat-soluble vitamin deficiency. So most patients who are cholestatic, they don't absorb the fat-soluble vitamins, which are A, D, E, and K. And so you have to supplement that. You really have to monitor their growth. So some of them might need, extra formula or higher caloric density formula. So that's something that you got to watch. And 20 to 30% require a liver transplant. So when do you do a liver transplant in a patient with Alagille? A lot of times their livers are not really failing. So I won't say it's always chronic liver disease, but sometimes it's because they're itching so much. Sometimes it's that their growth is so poor. So if they're not growing very well, that can be an indication to transplant them, because that if you test for things like insulin growth factor and growth hormone, you can see that it's due to their liver disease they're not growing well. And the 1-year patient survival is about 80%. That's lower than in other diseases such as biliary atresia, where it's probably 95% or higher. And it can be attributed to the fact that it's a multi-system disease. They have cardiac disease. Their vessels are kind of more fragile. And so it's a little bit harder to transplant somebody with Alagille syndrome. Alpha-1 antitrypsin deficiency, this is one of the most common genetic disorders in the United States, causing liver disease, and it results in reduced levels of alpha-1 antitrypsin. And it's a protein that's produced in the liver and excreted into the blood, and its primary function is to protect the lungs from the enzyme neutrophil elastase. And this is in 1 in 1,500 to 2,500 people. So the full deficiency is in patients who have ZZ, type, you'll have, if you ever send this, you'll see the normal is what's called, they give the result as an MM, so that's just normal. Then there's some who are heterozygous who are MZ. There's multiple other ones as well. So you can get this genetic sort of test. It's an easy test, and then there's something called the alpha-1 antitrypsin level, which is how much alpha-1 antitrypsin the liver is producing. So that's something important to get as well, so you know how much the patient is making. So liver disease, and this is caused by excessive amounts of the alpha-1 antitrypsin trapped in hepatocytes. So the liver produces it but cannot get it out of the liver. So that's the problem that we have with this disease, and it can cause inflammation. So a lot of the patients will have elevated liver enzymes even though they look fine and are growing well. And there's liver damage in 10% of infants born with severe disease, and they may go on to develop cirrhosis. What I tell families who have the ZZ type, which is the severe type, is that 10% of them will have some kind of liver problem, and now that might be just elevated liver enzymes, that might be progression to cirrhosis, but only 10% of those patients will need something like a liver transplant. So most patients with alpha-1 antitrypsin in childhood don't have a lot of liver problems. But we have transplanted patients who've had alpha-1 antitrypsin deficiency if they have severe liver disease in infancy. And sometimes when they grow older, one of the things we see is they develop adenomas in the liver, and that might be due to the progressive inflammation that they have. So all the irritation is causes these adenomas to develop. So you can have jaundice. I've sometimes seen sort of prolonged jaundice in infancy. So, you've all seen jaundice babies, and when we're wondering, is it breast milk jaundice, breastfeeding, or what kind it is. Alpha-1 antitrypsin kids sometimes will have just a prolonged jaundice up to 3 to 4 months that improves, and then they're doing well. But they can always have elevated liver enzymes. They can have acolic stool, so sometimes we've thought that they've had biliary atresia, and we've done biopsies, and haven't done like a Kasai procedure in one of them, but we do this. We do a cholangiogram to try to see if the bile ducts are open, and they've been open. So it can mimic biliary atresia. They could have difficulty feeding. They can develop portal hypertension as well, just as any patient who has chronic liver disease, and they can develop fatigue too. So the diagnosis is just with a simple blood test called the alpha-1 antitrypsin phenotype. And we can also diagnose it on liver biopsy. And so this little kind of globule is alpha-1 antitrypsin that is stuck in the liver. So there's a special staining that we do for it to look for it. And if you see it, it's diagnostic of alpha-1 antitrypsin. But hopefully it's something that you can pick up with a blood test before you have to do a liver biopsy. There's no specific treatment for liver disease with alpha-1 antitrypsin. You do a liver transplant for progressive liver injury. You can give enzyme replacement therapy for lung disease. And there's a lot of work going on in gene therapy for this illness because it's fairly common. Patients in their 40s and 50s are more likely to develop emphysema, especially those who are exposed to a lot of pollution or who are smokers. Those are pretty much guaranteed to develop emphysema, so that's one of the things that we counsel families against. They usually, as kids, don't see a pulmonologist, but once they get older in their teens, we will have them see a pulmonologist so they can talk to them more about the potential lung disease. Autoimmune hepatitis, it's in the family of autoimmune diseases, so I compare it to things like, thyroid disease, lupus, or diabetes. It's a global disease. It's another rare illness, 0.3 to 4 cases per 100,000 children. It's mostly found in females, so that's 70% of cases. It's a cause of chronic liver disease in 11 to 20%, and it accounts for 2 to 6% of liver transplant in Europe and the US. So not a common reason for transplantation. Luckily, we have fairly good medications that will, that you can treat somebody with autoimmune hepatitis with. but sometimes they come in what we call acute liver failure, and they require a liver transplant. So it's not 100% clear why some people develop autoimmune hepatitis. There are some, genetic factors. There's, antigen presentation, immunocyte activation, and then there's some triggering factors. So sometimes we've seen patients come with autoimmune hepatitis who've had infection with mono, or other viruses. Medications like minocycline or NSAIDs can do it. So, I think I've seen 2 who were on minocycline for acne and then have developed what looks like an autoimmune hepatitis. Other toxins can cause it as well, and so it can be a difficult disease to diagnose. But usually, I'll say it's fairly easily treated. So up to 45% of patients with autoimmune hepatitis will have another immune-mediated illness. So celiac disease is pretty common. Thyroid disease is actually the most common disease to have with autoimmune hepatitis. You can have IBD or PSC as well. So these patients who I will check every 2 years or 3 years for celiac disease and thyroid disease. If they have any bowel complaints, we are pretty quick to do a colonoscopy on them to look for IBD. And then PSC is another autoimmune liver disease. It's on one end of the spectrum compared to autoimmune hepatitis. We usually see autoimmune hepatitis affecting the liver and the liver cells, whereas PSC affects the bile ducts. And you can have what we call an overlap between them where both of them are affected. So other autoimmune diseases that you can see with autoimmune hepatitis, are the ones I listed before, plus Graves' disease, things like lupus, adrenal insufficiency, vasculitis, nephritis, Sjogren's syndrome, and autoimmune hematologic disorders. The clinical manifestations, in the end, you'll have things like portal hypertension. You can develop cancer if you have cirrhosis. That's a risk factor for anyone who has cirrhosis. And then the rest are sort of commonly seen in any chronic liver disease. I think one of the problems with autoimmune hepatitis is that it's very vague. People will present with fatigue or fever. A lot of kids are tired. They'll say they're tired, especially teenagers who are in school and doing a lot of activities. And people may think that there's kind of nothing going on, and they'll just present to us jaundiced. Up to 20 to 25% of patients or pediatric patients with autoimmune hepatitis will have cirrhosis when they come and see us. So they're generally diagnosed a little bit later than adults. This is what's called the simplified criteria for diagnosing autoimmune hepatitis. Like many autoimmune diseases, it can be difficult to diagnose, and so this International Autoimmune Hepatitis Group has come up with a scoring system that tells you whether something is unlikely to be autoimmune, likely, or definite autoimmune hepatitis. And so these are some of the tests that we get so that we can figure out whether or not they have autoimmune hepatitis. These are antibodies. This is called smooth muscle antibody. This is called liver kidney microsomal antibody. This is just the total level of immunoglobulins. This is, we have to get a liver biopsy. So if it's, compatible, meaning looks like autoimmune hepatitis, you get a score of 1, but if typical gives you the score of 2. And then, of course, you have to make sure they don't have a viral hepatitis, because that can cause sort of all the symptoms that we're talking about as well. So, and by that I mean, hepatitis kind of A, B, and C. So, it's like I said, it's usually fairly easy to treat, but it's lifelong therapy, and there's lots of different definitions for how well somebody is doing. So some of the treatment endpoints that we look at is whether or not they're in remission, whether they relapse after withdrawal, if there's something called treatment failure. There's something called an incomplete response where the patient will respond, but their liver numbers remain elevated. And then you can have drug toxicity too. So most of these patients are on a drug, are usually started on prednisone and on a drug called azathioprine or Imuran. And so that one can cause kind of GI upset, it can cause nausea, and it may require us to switch therapy. So in disease remission, you have disappearance of symptoms, you have near normalization of the LFTs, no hepatic inflammation, and it's the majority of patients within 3 years will be in remission. And your 10-year survival here is 90%. So now I'm going to talk about non-alcoholic fatty liver disease. Now it is now the most common liver disease that we see in children. Before, it had really been a really, I'd say, a niche disease that we didn't see much of, but it really has taken over our practice. And before I go on, I just want to ask if that's something that you guys see as well. If you see a lot of it. And how often are you checking liver numbers in a healthy kid? At their annual, you'll check it, but who do you choose?
Usually like early adolescence.
Would you do it in everybody, or do you just do it in overweight?
No, we do it in everybody.
In everybody.
Usually.
Okay.
Yeah.
So NAFLD it's a spectrum. It's usually defined as having greater than 5% of fatty infiltration by imaging or histology. And the imaging really has to be with an MRI to say it's 5% or not. You have to have no significant alcohol intake, no genetic diseases, and no medications. So you start off with NAFL, which is without disease. If you do a biopsy, you just see fat in the liver. So that sometimes they'll have elevated liver numbers, sometimes they won't. I think I've seen kids who've had a liver ultrasound where they say there is fat on the ultrasound, but they have normal liver enzymes. So that would just be called non-alcoholic fatty liver because it hasn't hit the disease sort of state yet, but they are probably on the path to hitting it and will eventually get there. The NASH, which is non-alcoholic steatohepatitis, you have on biopsy, you have steatosis with inflammation. And in the inflammation you see the liver cells are big, and you could have fibrosis and you may not have it. Then you have NAFLD with fibrosis or NAFLD with cirrhosis. So those are just progression of the disease. So this is the spectrum of disease of NAFLD in something called the NASH CRN, which is the Clinical Research Network. There's 176 kids in this, over 8 clinical sites. The majority of patients had either borderline or definite NASH, so we have 80% have NASH. The mean BMI is high, it's 33, and the percentile is 99%. Out of the patients with fibrosis, you can see about 30% have significant fibrosis, so what we'd call a stage 2 or stage 3, with some in stage 1. So stage 1 obviously is going to progress to stage 2, 3 if measures are not taken to reduce the fat in the liver. So what are the features that we see that are associated with NASH? So number one would be waist circumference. We often see patients with insulin resistance who are pre-diabetic. We see it more commonly in Hispanics, greater than whites. There's a genetic polymorphism called PNPLA3 that's been found to be associated with increased amounts of NASH. Older age, now older, I would say we see the most common patient we see is like, I'd say a 12, 13-year-old Hispanic male with this. Elevated ALT, so greater than 80, plus high AST and GGT. They often have dyslipidemia, but they don't always have dyslipidemia. So they often have high triglycerides. Their cholesterol is usually is normal. there's very few or no studies describing the incidence of NAFLD in children. There's a lot of sort of single center type of studies that have shown that it's increasing in number. There's a lot of work going on in California because they have the Kaiser system, collects data from a lot of kids, and so they've shown that the incidence has increased over time in Southern California. So it increases as age increases, so 17% in the 15 to 19-year-olds, and it's more common in obese children, so 29 to 38% of obese children can have NAFLD or NASH. And so there's a fourfold increased risk for Hispanic children, less common and less risk in Asian, white, and in black children. But we see it in all ethnic groups. It's present globally as well. So the prevalence of NAFLD parallels the growing prevalence of obesity in kids, and it varies with the population screened, the level of risk, and what you use to detect NAFLD. So oftentimes when I see a patient with it, I'll ask the family how many other kids they have and whether they're overweight or not. And sometimes they say, all the kids are overweight, some of them have been screened and some of them have not. So I always encourage if one of them has it for the rest of the family to get screened as well. So it's the prevalence of pediatric NAFLD is higher obviously in overweight children, in males, in Hispanics, those who have prediabetes, patients who have obstructive sleep apnea, and anyone who's got hypopituitarism. So I'll talk a little bit about screening. Different labs use their local population for norms. The median upper limit of normal at some children's hospitals had been 53 units per liter, but in the NHANES group, the upper limit for normal is 25.8 for boys and 22.1 for girls, which I'll say to me is really low, and it's very. I guess I don't see anybody with normal LFTs because then they don't come to me. But I'm sure you guys will see some like this. It's really difficult to get anyone who has NAFLD down to this normal number. But we do, with diet and exercise, you do get some of them there. So screening should be considered between 9 and 11 years for children who have an elevated BMI, or children who are between the 85th to 94th who have other risk factors like prediabetes, insulin resistance, or central adiposity, or a family history of NAFLD or NASH. So you can perform earlier screening in younger patients with such risk factors like severe obesity, and consider screening of siblings and parents if they have a known risk factor for NAFLD. So the best test that we have right now is ALT. So the sex-specific upper limits are 22 for girls, 26 for boys. If you have persistently elevated ALT, more than twice the upper limit of normal, so that would be sort of in the 50s, greater than 3 months, they should be evaluated for NAFLD. And an ALT greater than 80 warrants increased clinical concern. I don't know what your guys' practice is for referring patients. Do you do 2 or do you do just 1 if it's high? And I guess it depends too on the family and on the patient. So, I'd say I like to see at least 2 spaced at least a month or so apart. Elevated ALT can be caused by so many different things. Viral infections can cause it, and so if you wait about a month and it's still high, it's unlikely to be a virus or something that's passing, and it's more likely to be a persistent problem. And I know we have a very long wait time to get patients in for a lot of things, but if they have high liver numbers and somebody's worried about it, I think you can always call and ask to speak to somebody on call, and we'll do our best to get them in sooner. So regular ultrasound is not recommended as a screening test for NAFLD. You can do it. It's not something I do as a sort of as a first line when I see a patient. You should repeat ALT every 2 to 3 years if the risk factors remain unchanged, and consider repeating screening if clinical risk factors increase. For screening, one of the sort of newer modalities that we have is something called either FibroScan or ultrasound with elastography. So what the FibroScan is a machine that measures how hard or soft the liver is. So if if the liver is harder, then sound waves pass through it faster and you get a higher score, and higher score is bad. One of the machines has something called CAP, or attenuation parameter, and if that is elevated, if that's elevated up above a certain number, which is like 280, 290, it is 95% specific for fatty liver. That is something that people do in the office. We currently don't have one of those, but we're working on getting them. So if somebody comes to our clinic, it looks kind of like an ultrasound machine, like a portable ultrasound machine. We just put it on the patient's liver and we measure it like that, and we know kind of instantaneously what they have. And then we can use that to see if things have improved. So for example, if that parameter that we were measuring was 400, and in 6 months we check again and it's 250, then we know that at least the amount of fat in the liver has decreased. So it's something that you can use along with the ALT to sort of monitor progression. And so NAFLD, or NASH, is a diagnosis of exclusion. It is a hard diagnosis to make. We often, we'll send a huge workup on these patients because, you can have NAFLD and you can have any other disease with it. So we don't have a good treatment for NASH or NAFLD. And so a lot of it is wakeful watching and encouraging increased physical activity. And so we don't want to miss something that's easily treated. So we'll often look for, all these diseases, plus any viral hepatitis, plus autoimmune hepatitis. We have to ask about medication use. So obviously corticosteroids can cause it. Methotrexate can cause fibrosis and can cause something that looks like NAFLD. Antidepressants have been known to do it more so in adults than in children. Rapid weight loss can cause a fatty liver. Malnutrition we had a kid who was severely malnourished, and on their ultrasound they had what looked like fatty liver disease, but it was all which improved after their nutrition improved, so it was all likely due to their malnutrition. TPN, or parenteral nutrition, can cause it as well, or cause something that looks like it. So how do we diagnose it? We look at serum markers, so things like the ALT. We do imaging modalities. We still will use ultrasound because it's just easier to do. MRI can actually quantify how much fat there is. So you have to request it specifically, and they'll measure how much fat. So they'll say there's 10% fat or 15% fat, and then obviously there's liver biopsy, which we'll also do in certain cases. I'll usually do a liver biopsy if their liver numbers are very high, or if they've lost weight and the number has not changed, because that might mean that I'm missing something and it's not due to the fatty liver disease. So what do you want with the treatment is you want to have regression of NAFLD, so decrease in steatosis, so decrease in inflammation, decrease in fibrosis, and resolution of NASH, which means resolution of the ballooning of the hepatocytes under the microscope, and these are all determined by liver histology. This has been a problem in the development of medications for this because it's hard to do multiple biopsies on people, especially in kids. And so I know certain companies are trying to move towards some non-invasive methods, but I think getting the drugs approved is tough. You also want to look for things like decreases in their adiposity, improvements in their dyslipidemia, insulin resistance, and blood pressure. So potential treatments are, obviously lifestyle treatments, which are, the easiest to say, and I'd say the hardest to do. Dietary supplements, so things like we'll sometimes prescribe, vitamin D, vitamin E. I'll say those are the dietary supplements, not like so many others. Surgery, so bariatric surgery is possible. Bariatric surgery is uncommon in kids, and is probably done only in 16 years and older. It's obviously possible to do it in younger kids, but most programs will not want to do it in somebody very young. The medications part, I think, is very interesting. I'm sure everyone has heard of, sort of the new class of medications that are out, the GLP-1 agonists that seem to be, working really well. There's one of them called liraglutide, which is approved for kids 12 years and older. That is, you could possibly use. I myself have not started using it. I think it's just a function of getting comfortable using it. I know people who have not seen a lot of side effects. They have not needed a lot of monitoring on the patients. I was afraid of hypoglycemia, but that does not occur either. I think the time is probably now for us to put a lot of kids on it. They are injectable medications, so that's another hesitation on my part. I don't want to put them on something lifelong that's an injectable. I'm worried if you stop it, they'll gain the weight back. So those are all sort of my concerns and reasons for not starting. But there are patients out there who may just need it to give them that little kind of push to help them lose some weight so that they can continue on a sort of a healthier journey, and who have things like sleep apnea, diabetes, and high blood pressure, in whom this medication really may help reduce all those other comorbidities. So I'm cautiously optimistic about them. I think they're going to be used more and more, and so probably you'll be seeing kids on it, I'll say in the near future. But I'll say in my practice, we haven't started doing it widely. So the first line of treatment is lifestyle modification, so improving the diet and increasing physical activity. I thought as a trainee or before I had kids that this might be easier, but it's very difficult. I think a lot of times if you have both parents working, especially if they're working different hours, it can be difficult for them to have the kids, improve the diet, especially if they're relying on things like grandparents or fast food just because there is no time or the food is cheaper. So I think it's a good thing to say, but I think we should recognize the difficulties in doing this for everyone. Avoiding sugar-sweetened beverages is a key. Healthy, well-balanced diet, moderate to vigorous exercise. I think this limiting screen time is from 2017. I can't. I don't know how much screen time. How much screen time do you get? Say less. Don't tell. So there's no medications recommended for NAFLD or NASH. The medications I talked about, they're more for obesity or they're for sort of like diabetes. Bariatric surgery can be considered for those whose BMI is greater than 35 or who are looking like they have progressing towards non-cirrhotic. I wouldn't do it in a patient who is cirrhotic, and those who have other serious comorbidities. And that's all. Thank you. I'll be happy to take any questions that people might have.
For the biliary atresia, if they're like at the pediatrician for their checkup, it's still jaundice, would you recommend them getting a direct bilirubin or another lab instead of just assuming they're still jaundice because they're newborn? Is there certain labs you would like to see or help them decide if it needs to get referred to transplant?
Yeah. So there's I'll say there's an interest in requiring or asking for a total and direct bilirubin on all babies or all newborns, because it's been seen in these population screenings. If you have a direct bili greater than 0.4 at 48 hours, that a lot of those patients will have biliary atresia when they, by the time they're 2 months old. So it's a very sort of specific test. I think in most practices, you guys just have a total bilirubin. Is that right? But do you do both routinely? So yeah, we love to see a direct bilirubin because if the total is elevated even at like a 3 and the direct is a 0.2 and you call us, like we're not as worried as if the direct was a 0.8 or 0.9. So if it was 0.8 or 0.9, we would probably admit them the next day and go for a liver biopsy or see them the next day. But if it's more the indirect component, then that's likely to be, your more physiologic jaundice or breast milk breastfeeding jaundice. So, I think if you have an infant who you're worried about, whose jaundice doesn't seem to be clearing, I think, if you're at a practice that only does the total bilirubin, the next time you do it, you could ask for a direct bilirubin so that you can at least see what it is, so you can, in your mind know how urgent it might be to send to the gastroenterologist.
How does autoimmune hepatitis, how does it cause chronic liver disease?
I promise I didn't plant him.
Good question.
Yeah, because it's a question that's difficult to answer. So I'd say autoimmune hepatitis is a lifelong disease, and so it's something I would say becomes a chronic liver disease. It can be missed initially, and so if there's enough, if there's ongoing inflammation, that can cause scarring and fibrosis and cirrhosis. So it sort of becomes a chronic disease if it takes a long time to diagnose. Once you're on therapy, because you're on therapy for probably for life. Now we're able to take patients off of medication in about 20 to 25% of cases, but the other 75 or so will remain on medication. So that's what makes it chronic, because it doesn't go away. It stays. Yeah.
Medication talks about being reluctant. Was it because of the delivery? Was it because it is injectable? If it was oral, would you be more likely? I think so this is just, this is not based on a lot, I don't have a lot of experience with it because it's a newer medication. I think with all new medications, people who haven't been trained in their use can be a little bit reluctant, so I think in that camp. I think if it were an oral medication, I would be less reluctant to try it. With an injectable, patients have to be sort of taught how to do it. They have to get the supply for it as well. I worry about their, I think, I know it's easy to do, but I still worry about their adherence to doing, it's hard to remember, it's hard to take oral medications all the time, nobody likes to do it. And so I wonder if they'll be able to do this injectable all the time, and whether it really will be as effective as they, as the sort of the studies say, if you're only doing, instead of doing it daily, you're doing it like 3 or 4 times a week. It still may be worth doing, and I do think, we've talked in our division about sort of all of us, starting to do this. There are pediatric obesity courses that some folks will do, where they really teach you how to about all the different medications and what to do and what to use. Besides these ones, some of the other medications that people will use, so like I mentioned vitamin E, vitamin D, people will use things like carbamazepine, will use that. It's supposed to be sort of like an appetite suppressant kind of
kind of mechanism. It's also shown to decrease the ALT. The ones who are pre-diabetic will sometimes be put on metformin. Metformin can help with their weight gain. It can help with helps with their liver numbers as well. So there are other ones that have been used and are continue to be used. But I think out of all of them, these newer agents probably have the most promise, because they are, in some adult studies, they drop the weight by 10 or 15%, and I think, we all have seen the sort of the prevalence of issues in mental health in adolescents and in kids in general, and once you get to a state like that, it's hard to motivate yourself to get up and do something different. And I feel like if you could give them that little push, it would really help to maybe motivate them to either go out more or to watch their diet a little bit more, because they've seen some improvement. And so you've helped them with that, and then they can sort of take it on from there. All right, thank you.
Thank you so much for coming out tonight. I hope you enjoyed it, and I hope you learned a lot. Liver disease is not been respected very well, so we're trying to get the word out and get the awareness out, and we appreciate you coming to learn about it. Thanks.
Absolutely, thank you so much.